Hello and welcome to the Healthcare Today podcast. Our guest today is Dr Harvinder Power, a practicing clinician and the co-founder and CEO of Motics, a healthcare automation platform that provides AI agents for clinical documentation, billing, and patient communication. With its potential to streamline admin, increase capacity, and provide a better patient experience, today we're talking about how artificial intelligence can help private clinics scale without raising their operational cost. How much time is actually lost by doctors to admin? And to be specific, what type of admin eats up the most time?
So when we look at admin as a whole, I think there is a lot of conversation around documentation. I think that's the big zeitgeist that we're seeing at the moment, or where clinicians are spending the most admin. But I think the answer is actually a bit more nuanced in terms of admin as a whole, because I guess we need to remember that admin encompasses things like calls, emails, patient admin, patient requests, information, data exchange, and then, of course, documentation on top of that as well. What we tend to see, actually, when you look at the research, look at data that even we've collected with our customers, is typically about half of the day is spent in the patient management system or the EHR, whatever system of record they have in place. But actually, things like documentation is only about 20% of that time. And so actually what we tend to see is that it's that data, the ordering, the inbox management that tends to take more time. So actually more the 25% of the time. So with admin, we tend to see that it depends on the business, depends on what they see, but generally there's a lot of conversations around things that doctors focus on in terms of their day-to-day, or clinicians focus on day-to-day. But there's still so many opportunities to really help clinicians in terms of how we servicing patients. Are we missing any information that we would capture in that admin cycle of treating that patient?
So where can AI and automation help save clinician time and availability?
I think the answer is nuanced because it depends on the organization in many ways, and not just in terms of the time save, but also the patient safety in terms of this as well. So, for example, if we look at recent data, so there was an Oxford study that was done where they piloted ABT technology, so a few different vendors, and they looked at, can we save time in terms of critical admin, but also what are the second order effects of this as well. So they found about 85% of users did save time, but actually that was time saved in writing content. They actually increased it in terms of the reading and reviewing of the content. So what we do see is that I think the answer isn't necessarily very simple with stuff like this. What we tend to see is almost a reallocation of time. I think that may be the better way of phrasing this, is that we may reallocate time from writing content and doing the orders to now, as clinicians, to be focused on reviewing and managing teams of AI agents or even junior staff to ensure that they're actually doing things correctly. So for us, when we look at our data, we tend to look at clinical time measured through, are we actually saving time through the entire life cycle? So for example, in things like our scribe agent, where we generate content, we don't tend to look at the time taken to write the note. We'd actually look at the time taken to review, edit, finalize, what we call essentially the patient or the clinician satisfaction ratio. How many times are they satisfied with content they generate? And I encourage a lot of clinics and hospitals to really think carefully and deeply about the sort of KPIs and measurements they actually do and take when they actually look at assessing these technologies, because I think the answer isn't as clear cut, and there's often a bit of nuance in terms of where time is spent and allocated when actually adopting and addressing these in day-to-day practice.
When it comes to implementation, have you encountered resistance from doctors or admin staff? And if so, is the resistance about genuine tech phobia, or is it about bad experiences with clunky IT? Something I think we have all experienced at some point or another.
I may reframe this slightly, to be really honest with you. I think the resistance comes not from the tech phobia, the bad systems, but it's from previous history in many ways. I think it's from looking at historical experience they've had in the sector, where about 2/3 of clinicians say actually they're working out of hours and they're doing extra work just to keep on top of their daily patient load. But the reality is they want systems, but they want systems that are designed around them and for them, rather than ones that add to their admin workload. And so going back to what we were just saying, I think it's important when we look at adopting technology, assessing it for use in business, whether it actually fits into the life cycle of treating patients and also the clinical life cycle. Does it work in their day-to-day? Does it integrate well? Are the end users actually happy with the technology, and why are they happy? Can we try and recreate those effects? So for us, we come from the clinical experience background. Obviously, our team has a lot of clinical experience. We've spent time also looking at other providers in the market, and we focus on actually adapting the technology to the clinician rather than forcing the clinician to change their day-to-day practice. And I think that's really critical when you look at which companies are doing really well in the market and moving away from, here's another system to learn, towards your existing workflow is just now better, faster, and more efficient.
Now, burnout is often linked to paperwork as well as understaffing, moral injury, and rota gaps. Is automation just a plaster, or can fixing the forms genuinely move the needle on clinician well-being?
I think this is an interesting question because I think the answer depends on the organization and what their stance is on where the benefits and who realizes the benefits of the use of AI technology. So, for example, the recent data from PubMed, from the last study I looked at, said that after 30 days of AI Scribe, for example, again, a common use case people are familiar with now, generally burnout rates reduced from 52% to about 39%. So definitely improvement, right? However, I think the answer is more nuanced because what we typically see when we actually implement the technology is two things happen. Number one is that time is given back to the clinicians, they leave home on time and they get much better quality of life. Number two is that the clinics or the hospitals are just going to book in more patients. So the end clinician will actually just have more work to do because they're so much more efficient now. So again, it depends in terms of implementation, in terms of the practice, that provider, what do they tend to do? How do they want to implement it? What's the end goal for them? And how do they measure success? And I think that's what determines a good end user adoption, good rollout for the entire business versus ones that often stall because actually all you're doing is filling up more time for clinicians with more patients, which actually increases the workload. And ironically, you have the negative effect of actually increasing burnout because they're seeing far more work than they did previously.
Whilst the benefits of AI are very clear to see, there is still questions remains about human oversight. How much of it is still required? Do you still feel that the doctor still need to check 100% of the AI's output?
I think the answer is evolving because it depends in terms of government priorities and also liability. And I would say that the liability question is still the one that's biggest and most unanswered, I would say, at this moment in time. So, for example, who takes liability when an AI makes a mistake that could harm a patient? At the moment, that lies with the clinician because of how these systems are designed and how medical device governance is actually allocated. So, for example, to become a Class 1 medical device, generally, most ambient scribes in the market in that space focus on actually reallocating responsibility from the AI system to the clinician as part of that clinical review, or human in the loop, as people call it. Our stance is that is an important part of this life cycle, but it's not the end result. It's not where we should be going towards. And actually, we should be going towards AI systems that can safely and competently manage themselves, in many cases better than humans, which is our target. And that's how we realize the true benefits of AI as a society. Ultimately, is when AI can confidently take actions that are better and far less erroneous than human beings. I think that will take time. It takes some research, and we're doing a lot of this in our business as well, around how can we coordinate AI systems to work safely and securely at scale. But I think that comes hand in hand with regulatory bodies, with governments, and with healthcare systems to understand how can we implement and actually do this safely in the right way and in ways that are actually ultimately best for patients. So it's that full life cycle involvement and that governance, which is really important and key. And I think that answer is evolving even week by week.
Can we talk a little bit about how at Motics you actually do cover these subjects?
So in terms of Motics, we built our own guardrail system internally. So we have multiple agents that work together. They work like an AI team that's on 24/7. And for us, what we do is focus on how can we allow agents to work safely and collaboratively and escalate appropriately to humans when needed. So for us, that's our sort of stance. Obviously, some stuff I can't get into details of and how the specifics of that works. But we focus on how do we use humans appropriately to make the specific decisions that they need to and take actions we can take safely and securely, put the appropriate guardrails in place to ensure that we don't make mistakes.
Now, on the subject of adoption, do doctors and surgeries feel the benefits of implementation of AI immediately or only after a system-wide adoption?
What we tend to see is that adoption comes over a period of time, let's say typically a few months. And we start seeing early benefits very quickly, typically in the first 2 weeks, and then start seeing second order effects in the next 3 months. That tends to be what we see when we deploy technology, for example. And the reason is because they find new use cases and novel use cases once they become more familiar with the technology and how it works and where they can reapply it in different areas of the business. So, for example, one business started off with our Scribe agent, very popular part of our stack. And they found initially that there was a fantastic time save and they had so much more clinician capacity because we had unlocked so much time for them. And they realized now that they had gaps in the diary because they had so much extra time to see new patients. And for them, the second order benefits were now we can actually use our phone agent from Motics to then book in more patients because they're having so many phone calls they can answer them for. Motics then start booking more phone calls. They increase their number of appointments by 30% by month 3. And actually that means more revenue for the business. And actually they're seeing them far more efficiently because the scribe agent unlocks more capacity for them. So what we tend to see is that when we deploy technology in our situation, we start to see early effects really quickly, but actually it comes from time and engaging with clients and customers to really understand what are the use cases beyond just the initial pain points that they have. How can we really become transformational to that business? So that can often take a few months.
On the subject of efficiencies, what admin tasks are genuinely automatable today and which aren't?
I think definitely an evolving question in terms of where we're at. As I'm sure, I think this may be my party line, I think, is that everything is changing so quickly, which is amazing. I think we're actually in such a nice time in terms of developing in this market. I'd say things that we can do really effectively with a high degree of confidence today, things like clinical note generation, appointment booking by phone or via web, insurance eligibility verification, patient reminders, billing code suggestions, all of this very much table stakes nowadays, very much doable in this market. What I think we're not there yet with are more the clinical decision making, so clinical triage decisions. I don't think we have appropriate guardrails and systems that are safe enough to do this at scale yet. Complex prior authorization, anything that ultimately requires empathy at this moment in time. I think AI systems don't have the same level of empathy as humans do on the whole. And things that are sort of more medical legal with clinical attestation, for example, things that go to court or things that need to be approved. I think there's still areas to develop on to ensure that they're safe and actually appropriate for those at the moment. But I say that ultimately that sort of the thing that underpins all of this is trust. Is do clinicians, do providers, do they trust the system? And so what we tend to work on with, obviously what we're doing is how can we work with our customers to build trust and they can believe in the system ultimately. And that comes from just testing it, building adoption and using it on a day-to-day basis. And so we tend to see is that when they start building trust, they're then able to think of new use cases and what they can automate that they never thought of before. So things like reports, for example, is a new one that we see a lot of use cases on, of things that typically took them 6 hours to do. They thought, there's no way I can do this in Motics. But after about 2 weeks, couldn't believe I never thought of it before. So we tend to see actually our customers, people we engage with, they come up with the best use cases because everyone's living the problem on day to day.
If automation goes wrong, how do you handle mistakes?
So I think having sort of AI governance and patient safety as top of mind is absolutely important. That's the reason why we have protocols and processes in place, which is part of the reason why we're a regulated Class 1 medical device with the MHRA. It ensures that every action that's taken by the agent, for example, is logged, it's attributable, is auditable. It means that essentially you've got a perfect audit trail of every single decision that an AI makes and why it made it. It's going to reason through its decision and why it came to it. Obviously, the reality is AI is not perfect at this moment in time. There's still room to grow. There's still room to develop. And there's still room to learn, both on the human side and the AI side. What I think is important, though, is that auditability, transparency, and traceability, so that if a mistake does happen, firstly, we mitigate the risk of it and the severity of it. And on top of that, we then understand why it happened and rectify it. Because otherwise, if we allow these systems to run amok with patient data, obviously the risks are severe. And some of them may be life-threatening. So what we need to do is ensure we built, as part of that trust, that auditability, transparency, traceability through the entire stack from day one to show that on a day-to-day basis, you can interrogate the data and you can see where decisions are being made, why they're being made. And obviously you can go back and then see whether they're appropriate for that. And that's the sort of difference we tend to see from a lot of solutions that are almost like vibe coded nowadays. I think it's a big term that's floating around versus, I guess, a more medical device grade platform, something that's really been built with clinicians in mind and clinics in mind, to focus on how can they use and adopt these systems safely and at scale.
Now, we can, by this conversation, assume that AI is very much here to stay. I think everyone can see the benefits of it. But to your mind, what are the barriers to adoption? Is it procurement? Is it integration, cash? Is it culture?
Combination of all of them. But I'd say the key drivers within that list is probably procurement, regulation, and perception. I would say is the final one, maybe culture. I'd say that we are improving to procurement. Obviously, private sector differs from public sector. Public sectors and obviously has a new NHS framework to allow for adoption of things like ABT and other systems and AI. Obviously, is changing on a day-by-day basis, but we're seeing there are some improvements there. Even in the private sector, we've seen that, for example, culture is the big one. How do people believe in the AI? Do they trust it? And does it integrate? We call it the two deadly gases. It's integration and end user adoption. Firstly, does it integrate with their patient management system, with their electronic health record, with the systems of record that they need it to? And the second one is end user adoption. Are the people who actually would be using this on a daily basis actually going to use it? And we're seeing some research coming out not in the healthcare space directly, but in allied fields, which says that actually that end user adoption is probably the hardest piece of the puzzle. And it's really because people are worried about AI. They think it might take their jobs or may even make mistakes and they have to become liable for them. And I think that's a key thing that we must work hand in hand with, both in terms of AI vendors, but also in terms of clinics and hospitals, to show them and show and teach and educate the market to say, here's what AI can do, what it cannot do, here's where it should be used, and here's where it should not be used. And I think that's an important, honest conversation that needs to be had in the market to say, should we use this for the betterment of our patients? Or should we not use it for these specific use cases because it's just not there yet?
There have been fears raised that automation could risk depersonalizing care. Is that a fair statement to you?
It's a good question. I would argue that depersonalization has probably already happened, where clinicians now spend more time looking at their screen than at patients. And I think that probably happened a long time ago. And I would say that what we need to move towards is AI handling the tasks that would take us the most time, that sort of 50% time in the EHR, as we said earlier, so that clinicians can really spend more time with patients and actually improve that personalization of care, actually giving recommendations on treatment where appropriate that are personalized and tailored towards that patient. I think there's still a ways to go. I think we're still really early. The market is moving so fast and things are changing so quickly. But I'm quite optimistic that I think AI opens up the opportunity to personalize care to that patient and allow clinicians to spend more time on being human rather than data entry.
Now, as we've established, this whole technology is moving extremely fast. I could talk to you next week and I'll be learning new things from you. While Motics is presently focused on helping private clinics, where do you see yourself fitted into the NHS's shift towards community care and neighbourhood care in the future, should you go down that road?
I mean, we do some work with the NHS behind the scenes, but what I can say publicly at this moment in time is that we obviously support a lot of different allied healthcare professionals in a lot of different capacities in order to deliver that multidisciplinary care that ultimately we've now come to love and expect from our day-to-day care in hospital. So the way we tend to work is focusing on how do we support these smaller distributed teams to allow AI to help orchestrate and almost oversee the care as well, to ensure that things don't fall between the cracks, because we have so many more touch points now with patients, but just far fewer and essentially just far more fragmented. So what we need to do is ensure that patient care, these clinical safety incidents don't happen between those different touch points where, let's say, somebody in the pharmacy side of the community is actually handing over to the GP, but information is not safely or accurately transmitted, and we then have medical error that comes of it. And I think the role for AI is almost active at the glue. They can help hold this together, be part of that solution to almost enable this new and next generation of healthcare. And so that's where we tend to see it is AI doesn't necessarily need to just be a sort of bolt-on, but it can actually become the enabler of this next generation of healthcare.
Harvinder Power, thank you so much for your time.
Thank you for having me.